So good afternoon, everyone. Today I will be talking to you about Osilodrostat, which is a new treatment for Cushing's disease. Okay, so I'm just going to go through what Osilodrostat does and briefly review the previous evidence. But the main focus of today's journal club will be the LINK-3 study, which is assessing its efficacy and safety. Now, the drug was approved in 2020 for treatment of Cushing's disease in the US and for Cushing syndrome in Europe. And it's indicated if pituitary surgery has failed or if it's deemed inappropriate in certain patients. Now, the figure here on the left-hand side is the adrenal steroid synthesis pathway, and outlined in blue is where the drug actually works. So it inhibits cortisol synthesis by inhibiting the 11-beta hydroxylase, and it also inhibits aldosterone synthesis by inhibiting 18-hydroxylase. The net effect is that you get an increase in the androgens, and this is because you get accumulation of your precursors, but also there is an indirect effect, as once you start treatment, you'll get a fall in cortisol, which will stimulate ACTH, which again accelerates this adrenal synthesis pathway.
Is it an enzyme inhibitor, or is it's more than one? Is it also on 11 as well as 18?
Yeah, so it's 11 beta and 18.
Okay.
Yeah?
Yeah, thank you.
So looking at some background studies, so in vitro studies using human adrenal cortical cells have shown that actually it's more potent than metarapone and ketoconazole in inhibiting cortisol production. The LINK-2 study, which is the predecessor, was a 22-week open label phase 2 trial and involved 19 patients with Cushing's disease. And these patients all had baseline 24-hour uniform cortisol levels that were 1.5 times the upper limit of normal. And in this group, 84% actually achieved normal levels following 10 weeks of treatment. Another small prospective study, which was over 12 weeks and included 9 patients with Cushing syndrome. So the source here was either the adrenal gland or ectopic ACTH. 67% actually normalized their urinary cortisol levels by the end of the study. So actually there is, good evidence and promise here. So moving on to the LINK-3 study, which is assessing the efficacy and safety of the drug. This was a multi-center phase 3 trial with a double-blind randomized withdrawal phase. Now, it was conducted between 2014 and 2017, and it was multi-center, so involved 66 hospitals or clinics spanning across 19 different countries. So the participants that they included were aged between 18 to 75 and had either persistent or recurrent Cushing's disease, and they were deemed not appropriate for surgery or had declined surgery or radiotherapy. They also actually included patients who did have previous medical treatments for Cushing's disease, so metarapone or ketoconazole, but they ensured that effective washout periods were done. At screening, they focused on these 3 main criteria. So they had to have a mean 24-hour uniform cortisol that was greater than 138 nanomoles, an ACTH that was greater than 1.6 in men and 1.1 in women. And they had to have evidence of pituitary dependent ACTH. And they defined this as either an MRI pituitary showing a lesion that was greater than 6 millimeters, an IPSS central to peripheral gradient that was either greater than 2 pre-stimulation or greater than 3 post-stimulation, or if they had had previous surgery, if histology and staining confirmed an ACTH producing tumor. Now, patients were excluded if they had had radiosurgery or conventional radio treatment in the past 2 to 3 years, or if they had pituitary surgery in the past 29 days. Patients who were on glucocorticoid treatment for the past week were also excluded, and if they had a high risk or actually had optic chiasm compression, then they were also excluded. So here is their study design and protocol. So the blue boxes indicate the open label Osilodrostat treatment, and the green boxes indicate where participants were blinded and randomly assigned to receiving treatment or placebo. Now, following screening, patients all started the study period 1, which was Osilodrostat dose titration, and the range was between 2 to 30 milligrams twice a day. Now, during this period, the dose was increased, obviously, if the cortisol levels were high, and reduced if they were too low. But also at this stage, if patients were developing symptoms of adrenal insufficiency, the dose was adjusted and reduced. By the end of the 12 weeks, the participants then continued a therapeutic dose of Osilodrostat, and if during this period a dose increase was required, they were deemed as not eligible for randomisation and continued on open label Osilodrostat for the rest of the study. Those that actually did not require a dose increase and had cortisol levels less than 138 were eligible for randomisation and were either switched to placebo or had continued Osilodrostat. Now, this phase, which they call the randomised withdrawal phase, lasted for 8 weeks. And following this, all patients were then on Osilodrostat until the end of the study, which is at 48 weeks. Does that make sense?
Yeah, that was very clear, and it's complicated, but it's a good study. Any thoughts, questions from anybody else?
What are they doing with all the other medications?
What are they doing with all the other medications, Amir's asking?
So if they were Maripone, they did washout periods. I can't remember the exact numbers, but they were either weeks or months of withdrawal washout period before they started this study.
Yeah, it's quite a wide dose range, isn't it? 2 to 30.
Yeah.
But still, I mean, it's a new drug. BD, yes, indeed. Okay. And then the actual random bit is only 8 weeks long, but still, it's interesting to see what they found. Okay.
Yeah, the dose range is because of tolerability. So when I've been speaking to the first author of this paper, actually, it's just because to get patients used to the dose. So they start at very low dose and titrated up. So that's the main reason.
What was the average dose in period 2 then, Bijal? Are you going to tell us that?
Yes, yep, I am going to go on.
Fine.
Okay, so in terms of the outcomes that they were looking at, so the primary was based on the randomized withdrawal phase, and it was the proportion of patient or participants with a complete response, and they defined a complete response as a mean 24-hour urinary free cortisol less than 138 nanomoles, and non-responders had levels that were greater than 1.5 times the upper limit of normal. Their key secondary outcome was looking at study period 2, and it was essentially the proportion of participants who had a complete response without requiring an increase in their doses. They also looked at other parameters such as the complete and partial responses at 12, 24, and 48 weeks. Also looked at the change in the 24-hour urinary-free cortisol from baseline, looked at cardiovascular parameters, health-related quality of life questionnaires, as well as the safety and tolerability. So in terms of statistical analysis, so the sample size, they based it on their primary endpoint, and they said that they needed 33 participants per group so that they could detect a difference of 40% in the complete response rate. And in fact, 132 participants would be needed so that at least 50% would be able to enter that 8-week randomized withdrawal phase. So around 200 patients were screened, and 137 met the inclusion criteria and were enrolled in study period 1, which was the dose titration phase. Here, 7 discontinued, and it was mainly due to adverse events. 130 participants then entered study period 2. So again, that was the continued therapeutic dose of Osilodrostat, and 12 discontinued at this stage, mainly again due to adverse events. So by 26 weeks of treatment, 118 participants had completed this. And at this stage, 47 were deemed or were not randomized because they didn't meet criteria, or it was just decided that they were to continue open label Osilodrostat until the end of the study period. And 3 patients discontinued here, again, adverse event or physician decision. The remaining patients were then randomly assigned. So 36 continued on Osilodrostat and 35 were switched to placebo. And this, during this 8-week period of the randomized withdrawal phase, 1 discontinued. And then following this, in study period 4, another 1 discontinued whilst on Osilodrostat treatment. So all in all, they had 113 participants who had completed the study at 48 weeks.
That's actually pretty good for a 48-week study, isn't it? Completion rate.
It's not bad over so many sites either.
Yeah, that's very good.
Okay, so in terms of what they found, so baseline characteristics. So they had 3 different groups. So the Osilodrostat, placebo, and the non-randomized. And I just want to point out that the non-randomized group actually includes the 22 that had discontinued before the study completed. And if we look at the median age, it was around 40. There was a female predominance. And interestingly, the placebo group actually had a longer duration of Cushing's disease. And their mean 24-hour urine-free cortisol levels were much lower compared to the Osilodrostat group. So again, whether that would have sort of implications on the treatment effect being observed. However, I will point out that just before the randomization began, both groups had similar urine-free cortisol levels. Okay, so then when looking at the results and looking at the Osilodrostat doses, so between weeks 0 to 24, 62% of the participants had a dose less than 10 milligrams, so actually quite low, and only 6 required greater than 20. And actually 73% ended up having a dose reduction. During the 8-week randomized period, the mean dose reported here was 10 milligrams once a day. Any questions about this slide?
No, that's quite clear. So it's a sort of, it's a 10 milligram dose is the thing. And Amir's suspicious. He wants to know, are they definitely not on any other treatment?
As in any medical treatments for the Cushing's disease?
Yeah.
They were on antihypertensive.
It's all stopped. It's all been stopped. Yes. Okay. So there's a group, it's only 8 weeks, but there are no treatments. Is that right, Bijal? To clarify, placebo group are on absolutely no treatment at all for 8 weeks.
Yeah, but they'll be on anti-diabetic medication.
Yeah, they'll be on treatment for their sugars and things, but still. Okay. Yeah, thank you.
So, this figure here shows the mean 24-hour urine-free cortisol before randomization. So here on the y-axis, we have the cortisol concentrations. Now each line represents a participant. The square box here is the baseline cortisol level, and the cross indicates the level at week 24. And as you can see, majority of the participants demonstrate a reduction in their urinary free cortisol levels. And in fact, 53% maintained a complete response, which was below the limit of normal, without needing a dose increase. And this is really their secondary outcome that they achieved. This figure here looks at the mean 24-hour urinary free cortisol at the start and end of randomization. And on the left-hand side, we have the Osilodrostat, and on the right is placebo. Again, your y-axis is the cortisol concentrations. Here, this time, your box is the level at the start of randomization, and the cross is the level straight up after randomization.
That's an 8-week interval.
Yeah, so 8-week interval. And so you can see that the levels are actually maintained below the upper limit of normal, and they found a complete response in 86%. In comparison with the placebo group, most of the cortisol levels increased over the 8-week period, and actually majority ended up having levels above the upper limit of normal. However, interestingly, a complete response was still seen in 29%. And if we think about these patients in a bit more detail, which were 10 of them, was it because that they had a higher baseline 24-hour urinary free cortisol, which was indeed found in 7 of them? Could it have been due to just fluctuations in cortisol levels that we all are aware about? Or actually, were we seeing some sort of delayed cortisol recovery after the Osilodrostat was withdrawn? So they then decided to stratify the data, and they categorized it according to the Osilodrostat dose less than 5 milligrams and greater than 5 milligrams, and again with a history or no history of pituitary irradiation. And they've basically just concluded here that despite these factors, a consistent treatment effect is observed. So now looking at the cortisol levels from urine, serum, and saliva. If I just orientate everyone, so the x-axis is your time in weeks, and your y-axis are the cortisol levels. The shaded area here indicates the randomized withdrawal period. And the groups that we should really focus on are the circles, which is the placebo, and the black filled boxes, which is the Osilodrostat group. And as you can appreciate, in all of them, the cortisol levels rapidly decrease during the first 12 weeks, and a slight increase is observed in the placebo group during this randomized withdrawal phase. They've also reported in the paper that aldosterone levels decreased, but there is no actual data that I could find in their supplementary figures either. So looking now at ACTH, so the levels generally increased throughout the study. And as we saw earlier, during the withdrawal period, the placebo group's levels slightly declined. However, they found no association between ACTH and cortisol concentrations. In terms of looking at the precursor hormones, so they found that 11-deoxycortisol levels were increased in both men and women. However, they tended to plateau or stabilize after 24 weeks. And the same effect was seen in testosterone in men and in women at the bottom. Sorry, I should say at this point, so although there was no official figures, they said that there was no association between 11-deoxycorticosterone and low potassium or high blood pressure either. So looking at cardiovascular disease risk factors, so they looked at these parameters at baseline and then how they changed at 12, 24, and 48 weeks. Now there was a decrease in weight, blood pressure, and HbA1c levels. Interestingly, HDL cholesterol had actually increased from week 12 to week 48.
Is this for all of them together, all 130 patients, including those who had a bit of placebo in the middle?
Yes.
Okay.
Yeah, these are all the patients.
Yeah.
So yeah, so there was a slight increase in HDL cholesterol, which they don't really comment on in the paper. And they've said that it's unlikely to be related to treatment. Additionally, at the bottom here, they also looked at the Cushing quality of life score, as well as the Beck depression inventory score, and found both of these improved by the end of the study. In terms of adverse events, so this is again of all the patients. So all of the patients reported at least one adverse event. Around a third were considered to be serious. And actually quite a high percentage needed a dose interruption or a change. There was one death, however, this was not related to treatment or due to the underlying Cushing's disease. Now, in terms of the most common adverse events, these included nausea, headache, and fatigue. I've highlighted adrenal insufficiency and glucocorticoid deficiency because they've separated them out. However, in the paper, they don't actually categorize or define what each one means. So I'm not sure if they've done this to kind of like create some sort of dilutional effect or...
There's a little star and a dagger next to it. Is there some sort of subtext against adrenal insufficiency and GC deficiency?
As in, it's just the way that the physicians had reported, because obviously when they're filling out the like questionnaires or their protocols, they tick whatever symptoms.
I see.
So it's just related to that. It's not because they didn't actually measure their blood pressure or their cortisol levels when they reported that adverse event.
No, but on this page it says adrenal insufficiency and then a little tiny star, which makes me think that it refers to something else. You see what I mean?
Yeah, as in, so because this is actually from their supplementary material.
Yes. Okay.
But yeah, so they haven't actually gone into details as to why those two are different.
Okay.
So yeah, so that was just one interesting point there. Treatment was actually discontinued in 13%, and 4% was related to adrenal insufficiency, and 4% because of pituitary tumor enlargement. However, they have said that the pituitary tumor changes are unlikely to be related to treatment, as they were seeing both increase and decrease in tumor sizes in both groups throughout the study. So they then looked at adverse events specifically in that randomized 8-week withdrawal phase. And what they found is, so they had the those that continued Osilodrostat and those that switched to placebo. Again, there was maybe a higher serious adverse event rate in the Osilodrostat group. Then looking at specific adverse events that were related to adrenal hormone and hypercortisolism, these are much higher in the Osilodrostat group versus placebo. Again, as I said earlier, they didn't see any significant events related to pituitary tumor enlargement or to QT prolongation and arrhythmias, with which Osilodrostat has previously been.
Yeah, it is amazing how one patient had hypoadrenalism on placebo. See, it's amazing, isn't it?
Yeah. That's why, because the thing is, in the actual paper, they've only published this. It's only when you actually look back at the supplementary material and look for all the patients, you see a lot more information.
Exactly. Okay.
So this is just a summary of the results. So Osilodrostat achieved a greater complete response compared to placebo. And actually 53% maintained a complete response without requiring a dose increase. And there was improvement in cardiovascular disease risk factors as well as quality of life scores. They have reported that it does not adversely affect the size of pituitary tumours. And the main adverse events was that related to hypocortisolism.
So what do you think of that penultimate one? Because it did make them bigger, and then they said, we'll ignore that. And then they conclude, this is very typical of drug company sponsored studies. It's because everyone's worried about this. If you block cortisol production, you found a rise in ACTH, as you showed. So,
4%.
yeah. So I think that's a bit naughty because it was significant. You just write it off. I mean, that's, there are things that you can write off, but that's the worrying one. That's a wrong conclusion, isn't it? Don't you think?
Yeah. In the paper, they said that there was a 20% decrease and a 20% increase in tumor sizes in both groups, and kind of basically said that that is the reason why they don't think it's treatment related.
Yes, and Jerry's pointing out that 1/3 is not randomized. So that's, yeah, a good point too. Sorry, carry on.
Okay, so yeah.
Yeah, we can hear you.
Okay. In terms of limitations, so obviously their randomized withdrawal period was only 8 weeks, which is quite short. And actually, you're probably not able to assess the full effect of the Osilodrostat withdrawal. They've also mentioned that longer term follow-up for efficacy and safety assessment is required. It would be quite useful to assess Osilodrostat in older patients. The oldest patient in this study was 70 years. And actually, they should try and determine if the cortisol diurnal rhythm is actually restored. Again, these patients.
Did they say that?
Yeah, they said that.
That's a very strange thing to say. But given a drug that blocks production, how can you get your rhythm back? Unless they give it at certain times. Sorry, carry on.
And then it was, these patients were on antihypertensives and anti-diabetic meds. And so it's not sure or clear what effect these were having on the results in terms of the improvement in cardiovascular disease risk. And they've also suggested that, more data on the effect of the drug on the clinical signs of Cushing's disease would be valuable. And they're actually going to be publishing this in a separate study. So they do have that data, but they're just going to publish it separately. And so, yeah, so that's it.
Thank you very much. Okay, I want to what Florian thinks about using this drug. Or Jeremy, or Amir.
So from what I know, can you hear me?
Yeah.
There's an echo somewhere. No. So it seems to me it seems to be much more potent. I know Jeremy pointed out that obviously it's not if the efficacy is not in all patients, and it's probably you think it's only 1/3 of patients, or 30%, but perhaps a little bit higher. But it seems to be the most potent drug we have so far. So certainly more potent than ketoconazole or metarapine. And I think from what I know, so after this study, actually, they start with much lower doses, even to avoid adrenal insufficiency, which seems to be the main problem. And all patients get steroids just as an emergency. And then the problem is then to monitor the cortisol levels. So that obviously need to monitor free cortisol, so urinary-free cortisol or salivary cortisol. That's a problem.
Would this be a good drug for block and replace?
Yes, so that's another option, but it sort of defeats the purpose a bit, doesn't it? Because but yes, I mean that potentially is another option, or if you can get if it's difficult to get control. There are side effects that you mentioned that as well, the hypokalemia. So sometimes they use spironolactone. I'm not sure whether they mentioned that in that study actually, but that's what's being used to counteract the effect. But I think it might be a useful drug for a subgroup of patients, where, for instance, where we don't have a surgical target, to buy some more time.
Yeah.
Don't want to go straight for adrenalectomy. Like one of the patients I discussed recently, and may remember, who had failed surgery once, and then there was no target. She had a methionine scan, we still couldn't see it. And I think it's just to have another tool to buy some more time. And in the meantime, there could be potentially a pituitary target that becomes visible.
Yeah. I mean, we have 3 patients now on metarapone, 2 on block and replace. Yes, 2 on block and replace, and 1, Ezra, is on just minimum dose metarapone. And they're doing pretty well. I mean, not that I want to do that. This is waiting for adrenalectomy. The other 2 are waiting for pituitary surgery, and they're delayed by having aneurysms and things. So that's a good group. The metarapone in these people seems to be working quite well, and for 2 of them as a block and replace, because it's so difficult. Well, that's a good. Okay, there's a question. How does it compare to metarapone? Because we're starting to get used to metarapone. I mean, the thing is, we do 1,000 milligrams of metarapone, don't we? Whereas this is only 10.
Yeah, so apparently it's much more potent. So that's why.
But when you say potent, I mean it's per milligram. So I mean it's a dose. Well, it's a dose toxicity ratio. So what you're saying is it's less than metarapone for the same effective dose. What do you mean?
Yeah, I'm not sure that it's comparable, really.
Yeah, it's more potent per gram because it is more potent, no doubt about that. But it doesn't mean anything really because of the toxic effects. But if the main effect is hypoadrenalism, then block and replace is all right.
But metarapone is supposed to work through 11 beta.
Yeah, metarapone works in the same way. Well, this is less specific. It seems to be two of the proteins, so I don't quite understand that. But
Why
okay.
can't we check the serum for metarapone? What's the difference? The mechanism of action is similar. No, but I think our monitoring for metarapone is through
Cortisol.
Morning cortisol.
So ideally, we'll do caught by LCMS. The problem is we haven't got an LCMS. We're using.
It's the same mechanism of action. We don't need free cortisol. They use it in the
Yes, yes. But that's true. We can use plasma cortisol. The DOC cross reaction is a problem in all non-LCMS assays, which is what we have. The thing is, LCMS delays it by. I mean, PRED is LCMS, and as you know, PRED takes about a week or 2, whereas cortisol comes out, with the sodium. So, that's the difference. If you have a non-LCMS assay, you get the result quite quickly. Walter, you're going to say something?
Bijal, did they say anything about hirsutism and also blood pressure, given it reduces aldo?
So blood pressure actually reduced. In terms of the clinical features, they haven't reported those. They're going to report that separately, which hasn't been published yet.
That's convenient. I mean,
There are some, yes.
Well, given this is young women, I don't think they're going to want long-term hair growth, are they?
Yeah.
I mean, it's odd that they wouldn't include that in this paper. It probably doesn't look great. I know it's predicted side effect, isn't it?
It is. It's a good point.
In practice, most of them receive spironolactone.
Okay.
To counteract the hypokalemia, and that may also help the hirsutism.
Yeah, we're now starting to give 2 drugs because one. I mean, it'd be
One
okay for me,
exercise.
but I suspect young females won't be so happy.
It's not really enough, isn't it? It's for a subgroup of patients, really.
Yeah.
I think the truth is we have no good medical treatments. Yeah, the good treatment is surgical. Medical treatments are poor second cousins, really. And really, we don't want to use them. We've got pituitary surgery, we've got adrenalectomy, and we've got radiotherapy, in fact.
But I think But we often have patients where we don't have a clear target, and that's actually quite common in Cushing's disease.
Yeah. And we are using metarapone
And
a
then
lot, actually.
I wonder whether if you had a good drug that could buy us time,
Yeah.
the target appears after years. So if you can treat the patient for 2-3 years with a bit of medication, and then you have a target that may actually improve outcomes. I don't know whether it's the case, but for those patients, it may be good.
Yes, I mean, if this is a drug without side effects, unlike metarapone, that would be different. But it sounds like it's similar.
Can I ask what the spironolactone, because if you're lowering cortisol and aldosterone, the potassium is already going up.
Okay, so the problem, no, so the 11-doc is the problem. The 11-doc binds to the aldo receptor. You can block that with spironolactone.
But you're also lowering aldosterone. What was the
Yes.
effect on potassium?
Do you want to just go back to that slide? Sorry, Bijal. I want to get that very first slide, the one with the pathway, that nice steroid pathway. Did you make these slides? They're very good slides.
Yeah, but I didn't draw them from
No, I
scratch.
know you didn't draw that, but I did like your timeline. That was excellent.
Do they
I thought that was the easiest way to explain it.
At the very start. Those blue and green boxes are yours, are they?
Which ones?
No, the what later. Hang on. They stay here. Stay there. Stay there. Okay. Okay. So I'm just pointing in this on the screen up here that you all can't see. But basically, if you look at cortisol production, so it shows you where these things block, and Osilodrostat is there in the blue box. I can see that. So the problem is that when you block this, you have a rise in there. Yeah, exactly. 11-doc, and the 11-doc and the one above it points to, go up to the 11-doc corticosterone. That's like aldosterone. So that will,
actual potassium if that's a
no, but that will cause a fall in potassium.
Did they not report potassium during the study?
Did they report potassium in the study, Bijal?
No, so association, a rise in the oxycorticosterone and low potassium and high blood pressure.
Okay, so this blue thing here just will be blocked by spironolactone. That is what they're doing.
Well, we don't know that they had hypocalcemia. It's a hypothetical.
Did they have? No, they didn't report. It's hypothetical, unless I think they did have hypertension, hypocalemia. Did they? Or mate?
Sorry, say that again.
Did they have hypertension and hypokalemia?
No, they didn't.
Okay, they didn't. You're right. Then it's yeah.
That's what I was told. So hypokalemia is quite common, but the blood pressure actually decreases, as Bijal says, and that's probably because the cortisol goes down.
Mm.
So can you use a side effect of the medication for benefits? So if someone doesn't have a target, can you use the drug to increase the tumor to get the target?
Yeah. Okay. So just to repeat what Alex asked, can you deliberately make the tumor bigger by blocking the cortisol and causing Nelson syndrome deliberately?
But we recently did. That with your patient, Karim, the one on metarapone.
Yes.
Repeat methionine scan.
Correct.
But we don't know. That's exactly the point. So if you can actually buy more time to then make it so that the target becomes more apparent.
Yeah, so there's two things. There's buying more time, waiting for it to grow, but also stimulating the growth by removing the brake, as it were. That's the same as metarapone. What I really would like to see is some kind of comparison now between this drug and metarapone. We really need a comparison. That will never happen.
No.
That will never happen, but we'll have to do it ourselves. Randomize. Well, this one, actually, there are two competing companies, and they're both very expensive, is what will be. This will be more expensive, probably. They'll try and, actually, it might be the same price because metarapone's really gone up in price since it's been bought over by whoever sells it now. It's oral, yeah? Yeah, 10 milligrams. Okay, that was really good. Thank you, Bijal.
What is the organism with 13 hearts and no other organ, Bijal?
I don't know. I don't know. Okay. Amir's been affected by your emails. Yeah, no, there's no feedback, okay? No feedback. Okay.
But currently, it's not available in the UK
Yes.
and the US.
It's not in the UK, only in the US and Europe. Yeah. Okay. So we're stuck with methamphetamine, but that seems to be working for us. I haven't been easily able, in fact, I haven't used it for a long time, any ketoconazole. It seems to be more difficult. The same company that make methamphetamine have bought that one as well. So I'm sure it'll come back very, very expensive. Ketoconazole was withdrawn as an antifungal because it used to cause liver problems because it was so widely used. If you use it rarely, it's safe. But if everybody's on it for a little fungal infection, it was used for, like, you know, toenail infections and things. Yeah. Okay. Thank you very much, Bijal. See you all next week.
Yep, see you all next week.